Good morning, everybody, and welcome to Health for the World's International Grand Rounds. My name is Dr. Vidya Prakash. I'm an infectious diseases faculty at Southern Illinois University School of Medicine, where I also serve as officer and Associate Dean of Clinical Affairs and Population Health. I am delighted to welcome our guest speaker today, Dr. Sana Waqar, who is a cherished colleague and leader at SIU School of Medicine. She also serves as an infectious diseases faculty and as the Associate Program Director of the Infectious Diseases Fellowship Training Program. And Dr. Waqar also serves as lead of antimicrobial stewardship and infection prevention at Springfield Memorial Hospital. Dr. Waqar will be sharing her expertise on infective endocarditis. And without further ado, I will hand it over to her. Dr. Waqar.
Thank you, Vidya, and good morning, everyone. I'm not sure what the local time is there, but here it's morning, so good morning. I'm gonna share my screen. Is everyone able to see this? And is everyone able to hear me?
Yes.
Okay. So today I'm going to be talking about infective endocarditis, and I'm going to start the talk with a case that actually we saw last month. So the outline of the talk is we're going to talk about epidemiology of infective endocarditis, the pathogenesis, the risk factors that put patients at risk for endocarditis, the microbiological agents involved in this disease condition, diagnosis, and then management. So this is a patient that was on our service last month. He's a 49-year-old male with a history of recreational drug use. So his history is he does report injection drug use, and he also has chronic back pain, who presented to the ED with a 1-week history of generalized weakness and worsening lower back and neck pain. On initial examination and his vital signs, he is tachycardic, had a fever, but his blood pressures were fortunately within normal limits. Labs, he had elevated white blood cell count, an elevated BNP, and transaminitis. So his AST and ALT, his liver enzymes were elevated. He had blood cultures drawn on admission, 2 sets, and obviously we did not have this information at that point, but within 24 hours, both sets were flagged positive with gram-positive cocci. So next step, because of his history of injection drug use and because of his bacteremia, the workup proceeded with doing a TTE, which is a transthoracic echocardiogram that showed left ventricle size was normal, left ventricle systolic function was normal. There was no left ventricular hypertrophy, basal inferior and septal inferior were hypokinetic, sorry. And overall, basically, not too alarming a read on the transthoracic echocardiogram. So subsequently, over the course of his admission, whenever we have positive blood cultures, we repeat the blood cultures within 24 to 48 hours to have an idea of whether the infection is clearing or not. So repeat blood cultures were obtained on the 17th, 18th, 19th, 21st, 22nd, and 24th. And all of these were positive with the same organism, which is MRSA. So the initial gram-positive cocci were eventually identified as methicillin-resistant Staph aureus. And subsequently, all the blood cultures, as you see the timeline, were also positive for the same organism. So if we had to define kind of this pattern of bacteremia, this gentleman has high-grade persistent bacteremia with a gram-positive organism. So finally, on the 26th is when we have our first set of negative blood cultures, and then repeated on the 29th of January, they're negative again. So because of its high-grade persistent bacteremia, we went on to do a transesophageal echocardiogram. And this showed a vegetation on the lateral aspect of the mitral valve, mostly involving the A1 segment, and it was measured as 1.1 into 1.1 centimeters. It was moderate mitral regurgitation. The left ventricular size was mildly enlarged, and the EF was relatively okay at 60%. So remember this when we talk about whether, in diagnosis of endocarditis, we should do a TTE or TEE. So they remember this scenario when we talk about that. So what is infective endocarditis? Infective endocarditis is an infection of the endocardium. So any part of the endocardium, whether involving the heart valves or not, or heart valves. And this is important because there are a lot of things that, our patients have intracardiac devices now, they have pacemakers, and these leads and artificial material of these devices are actually in contact with the heart's endocardium. So if there is a lead vegetation, for example, on a cardiac device, by definition, that is also infective endocarditis, even if the valves do not have a well-defined vegetation. So infective endocarditis, we're seeing increased incidence, not only in the US, but also worldwide. And there's a lot of reasons for that. One is, a patient population, patients are living longer, which leads to increased wear and tear and degenerative changes in the heart valves, which in turn puts them at risk for infective endocarditis. Besides that, we're doing a lot more invasive things to our patients. So we're putting a lot more cardiac devices. There are a lot more people with more kind of aggressive medical management. So, dialysis patients with a long-term IV access, all these things put them at risk for transient bacteremia. And in the setting of a valve that has had wear and tear, that kind of puts them at risk for endocarditis. There has also been an increased practice of high-risk behavior, such as IV drug use, which also puts our patients at increased risk for endocarditis. It is associated with quite a bit of morbidity and mortality, and also healthy life years lost. So basically, a lot of people lose their productivity when they encounter this diagnosis. Some people end up having a bad outcome, such as death, but a lot of morbidity associated with it too. If untreated or improperly treated, it does have a high mortality, and it's the fourth most common life-threatening infectious syndrome. So pathogenesis, so how does this develop? So normal valvular endothelium or endocardium is resistant to bacterial colonization. And what that means is that if, for example, an animal model, you have an animal with a very healthy valve endothelium endocardium, and you give them transient bacteremia, it will not end up, they will not end up having infective endocarditis. So what you need is the perfect storm. So you need a valve or valve surface that is damaged, has damaged valvular endothelium. Now, whether that be because of iatrogenic causes, because they have turbulence, because of stenosis of the valve, or whether this is because of underlying rheumatological heart disease, or whether this is that degenerative valvular disease. So basically, you need to have an abnormal damaged valvular endothelium, and then you need a bacteria or microorganism that is very sticky, if you may. So something that has the ability to adhere to this damaged endothelium to result in this vegetation. And that's why, when we talk about microbiology of endocarditis, gram-positive organisms are more likely to cause endocarditis than gram-negatives because of their pathophysiology and then, their kind of virulence mechanisms. Their adherence properties are much stronger than you would see with gram-negative organisms. So that's why, layman terms, more stickier than gram-negative organisms. That's why they're more likely to cause infective endocarditis. So this is just what I spoke about. So basically, again, you need the perfect storm. You need a pathogen to gain access to the bloodstream, whether this is because of injection drug use, or somebody has bacteremia because of infection, or a catheter, dialysis. And then that bacteria needs to stick to a surface that has been damaged by either degenerative changes or underlying rheumatic heart disease. And because of that, once it sticks to that damaged endothelium, there's proliferation with, fibrin matter and the endothelial cell platelet complex, and this is what kind of results in vegetations if you see in D. So this kind of collection of debris is what results in a vegetation. And then parts of this vegetation break off, and that's what results in your septic emboli. So spread of the infection to other parts of the body. If it's left-sided endocarditis, you see septic emboli to the brain. If it's right-sided endocarditis, you see septic emboli to the lungs. So basically, formation of this vegetation and then dissemination by embolic phenomena. So risk factors. So old age, in the United States, rheumatic heart disease is not as big of a problem as degenerative heart disease. As I said, patients are living longer because of healthier lifestyles and because of kind of advances in the medical field. So more at risk to develop degenerative heart disease and then serve as a surface for endocarditis to develop. Healthcare associated endocarditis, again, we're putting many more lines. We're more aggressive with our approach to managing medical conditions, which puts patients at risk for not only bacteremias, but also damaging valve surfaces. For some reason, male sex is a risk factor. IV drug use, again, this results in transient bacteremia. Poor dentition, same concept, oral flora, transient bacteremia, more likely to adhere to a damaged heart valve. Comorbid conditions, anyone with structural heart disease, whether this is congenital or acquired. Prosthetic heart valves, again, these organisms are likely to make a biofilm on artificial material more so than natural valve surface. Cardiac devices such as pacemakers or ICDs, prior history of endocarditis, and the concept is the same. Prior history of endocarditis is going to render the endothelium of the heart valve damaged or unsmooth, putting patients at risk for further episodes. Presence of intravascular catheters and then hemodialysis. Again, these two put the patient at risk for transient bacteremias. Microbiology, the most common group of organisms to cause endocarditis are gram-positive organisms, whether it be streptococci or staphylococci. They account for 80% of all cases of endocarditis. And again, as I mentioned, has to do with kind of their virulence factor and the fact that they have very strong adherence properties, making them very sticky and very effective to adhere to damaged surfaces. Other gram-positives, enterococci, strep bovis, coagulase negative staphylococci. The biggest next group of organisms or next group classification is culture negative endocarditis, which is basically, the patient has endocarditis, but you failed to identify a microorganism on blood cultures. Now, there are a couple of reasons for this. One, the most common reason for culture negative endocarditis is actually prior antibiotic use. So especially in the setting of subacute endocarditis, these patients present with a very indolent course. So maybe low-grade fever, malaise, feeling fatigued for a duration over weeks rather than days. Because of this, they see their primary care physicians who, thinking this may be something infectious, they get a round of oral antibiotics. And that round of oral antibiotics is usually enough to make cultures negative. So if you're dealing with an endocarditis, history of recent antibiotic use is very important, even if it is a course of amoxicillin or a Z-Pak, which is azithromycin. It would make it important to kind of figure out whether this is culture negative endocarditis because of prior antibiotic use. The next kind of subset within this group is the Haysick organisms, which is your Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, and Kingella. And all these organisms are known as fastidious organisms. What that means is that these are very hard to grow in culture. So even though we know clinically there is an endocarditis, we know it's likely bacterial. When you do blood cultures on these patients' blood cultures are negative. And it has to do with the fact that these fastidious organisms are very hard to grow in the lab. The other subset you need to kind of consider is zoonotic infections, Bartonella, Brucella, Coxiella, and which one you are suspecting will be based on their exposures and their history. So a good kind of social history in terms of if they have had animal exposure, if they have had recent travel, and if they've had animal exposure, what kind of animals, farm animals. So basically a good history would help you delineate that. How we diagnose zoonotic infections and zoonotic endocarditis is we can do serology, or now we do have PCR available on valve tissue in the United States that can be sent if they have a valve replacement. And then Whipple's disease is another one that can give you culture negative endocarditis. Gram-negative organisms and fungi make up the remaining kind of 10% of the causes of endocarditis. These are usually, in our practice, we see this not that often. When we do, usually the patients have multiple comorbidities. Our last gram-negative endocarditis was somebody who had an intravascular catheter, high-grade persistent gram-negative bacteremia, had an aortic, abdominal aortic aneurysm and had a stent there too, which was seeded. So basically, these are very complex patients with very complex medical histories that end up having gram-negative or fungal endocarditis. But so typically when we see patients with gram-negative or bacteremia or fungemia, we don't really jump to a TEE, which is a transesophageal echocardiogram. But if you have somebody with persistent high-grade bacteremia, it should raise the suspicion and you should go on to get a TEE. On the flip side, whenever you have a gram-positive organism, our threshold to get a transesophageal echocardiogram is very low as opposed to these organisms. With fungal endocarditis, usually again, very sick patients, sometimes seen in patients who use injection drug use. And again, persistent fungemia should tip you into thinking that an endocarditis may also be present. Okay, so these are kind of like a table of, causative organisms with in relation to underlying risk factors. So injection drug use, you can basically see anything, but again, gram-positives kind of make up the bulk of the microbiology. With catheters, again, gram-positives, but since these are medical devices, patients have a lot of medical, exposure to the medical field, gram-negative organisms and fungi are also fair game. Patients with history of, genitourinary problems, gram-negatives are more of an issue there. So basically, you don't have to memorize all of these, but kind of make yourself familiar with them. And again, these are just kind of a guidance of what organisms you can see in the setting of certain risk factors, and where it helps us is to pick empiric antibiotic therapy when these patients present to medical care, because eventually how you treat your patient will depend on what organisms you isolate in the blood cultures. Now, if you don't isolate an organism and it is culture negative endocarditis, then again, these risk factors will help you pick an empiric regimen to treat your patients. This is kind of like a zoonotic slide. So cat and dog exposure, you can see Bartonella, Pasteurella, Kepna, Cytophaga, with contact with contaminated milk or infection with farm or exposure to farm animals, Brucella, Coxiella, homeless, body lice, Bartonella again, pneumonia, meningitis, strep pneumo, solid organ transplantation, basically anything including fungal. And then GI illnesses, you can see strep galolyticus, which is also known as strep bovis. So this is a slide which breaks down organisms with regard to the age of your patient. And there are a couple of trends I would like you to pay attention to in this slide. So these are kind of the colors. So yellow is coagulase negative staph, green is Staph aureus. Oral strep is basically these kind of blues. So what you see is when patients are younger, what you see is that the bulk of the infections are caused by very virulent organisms such as Staph aureus. So the thought process is that when patients are younger, hopefully they don't have that much valvular wear and tear or degenerative valvular disease. So the organisms that cause endocarditis in the younger age group are very aggressive organisms such as Staph aureus, so either MSSA, which is methicillin susceptible Staph aureus, or MRSA. So, the very virulent organism in the setting of hopefully a relatively normal heart valve is what's causing kind of the infection up in the younger age group. Strep is present throughout, I want to say. But look here, as patients get older, this yellow block starts to appear. And this is coagulase negative staph, which we know is not that virulent in terms of its properties of pathogenesis. But the thought process here is as patients get older, their valvular surfaces are more degenerative. So even the less virulent organisms, such as coagulase negative staph, is capable of causing an infective endocarditis. So basically, that is the one concept I want you to pay attention to. Okay, so clinical presentation. So it's very variable, and practicing here in the United States, again, it could be anything, and it really depends on how sick or how many comorbid conditions your patients have, plus what organism is causing the endocarditis. So if you have a Staph aureus acute and bacterial endocarditis, patients present very rapidly. So acute, rapidly progressive illness, high-grade fevers, plus minus septic shock. Patients obviously feel bad enough to come to the emergency department and to be admitted right away. Now, compare that to a coagulase negative staph subacute endocarditis or a strep endocarditis. Patients may have a more indolent course, loss of appetite, sweats, fatigue, myalgias, malaise for the past, over a span of weeks. And that's when they go see their primary care doctors and prescribed antibiotics. And really they have this subacute illness, but no identifiable cause, at least upfront. You do see fever both in the subacute and the acute forms, can be associated with chills, anorexia, weight loss. Other symptoms, kind of whole body symptoms, but if the endocarditis has progressed to a point where you've had septic emboli, symptoms will be present based on the destination of the septic emboli. So if it's going to the lungs, patient may have a cough, pleuritic chest pain. If it's gone to the CNS with left-sided endocarditis, you may see confusion, loss of consciousness, headache. So basically, depending on where the embolic phenomena has occurred. Clinical signs, you will or should be able to appreciate cardiac murmurs in most patients. If patients have an underlying cardiac murmur, change in the character of murmur can be appreciated. And then again, you may see or may be able to witness or elicit clinical signs depending on septic emboli. Splenomegaly can happen, and then cutaneous manifestations, you can have petechiae, splinter hemorrhages, Janeway lesions, osseous nodes, and rod spots, and I'll show you pictures of those. So these are splinter hemorrhages, kind of these linear looking marks in the nail bed. How you differentiate this versus trauma, in somebody who does a lot of, a mechanic or somebody who works a lot with their hands, you may see trauma-related hemorrhages too, but they're more kind of at the tip of the nail as opposed to splinter hemorrhages from endocarditis. Because if you kind of think about it, the splinter hemorrhages here in endocarditis are coming from the bloodstream, so they're going to be more kind of proximal as opposed to more distal in somebody who has trauma-related hemorrhages. Then you see this rod spot in somebody's retina. Again, this is embolic phenomena to the retina. Patients may or may not have visual problems or visual deficits, but a detailed retinal exam is needed to see these. Janeway lesions, these are basically happen as opposed to the nail beds happens in the palm. And bacteria, in this patient, bacterial endocarditis due to strep bovis. These are non-painful, they're macular and erythematous and can be located on the soles as well. So a detailed clinical exam is very important to kind of elicit these clinical signs. Ocular nodes in infective endocarditis, these are tender as opposed to the previous ones. They're papulopustular, so if you kind of palpate them with your eyes closed, they're more palpable as opposed to the previous ones, and they're located in the pulp of the finger. And the previous ones were more on the palms and the soles. And in this patient, the patient had Staph aureus bacteremia and infective endocarditis. Okay, so complications. Embolic phenomena can go anywhere, and basically it's going to be defined by what kind of endocarditis your patient has, left-sided or right-sided. Typical places we see is the brain, and again, in the brain, it can initially just be, and you can identify the emboli based on imaging, but over time, if you think about this embolic piece of stuff that came off from the heart valve is infective and has bacteria on it, so it can eventually proliferate and give rise to a brain abscess, a pyogenic brain abscess. And if these abscesses kind of spill into the ventricles, you can actually see a ventriculitis as well. That's basically purulent matter within the ventricles. And when you do a lumbar puncture in these patients, it's basically frank purulent matter coming out. How that's important from an infectious disease standpoint is obviously they need neurosurgical evaluation, but sometimes we can use medications such as rifampin for improved clearance of ventriculitis. And sometimes we can also use intraventricular antibiotics to help eradicate the CNS infection. You can see septic pulmonary emboli in the setting of right-sided endocarditis. And again, initially these kind of appear as multiple nodules in different areas within the lung. And these eventually cavitate, can become microabscesses, and other complications include empyema, especially if they're kind of close to the pleura. You can see septic splenic infarcts, and these can result in septic, abscesses within the spleen and the liver as well. Broad spots, we looked at a picture earlier, and then obviously these emboli can result in digit necrosis as well. This is a picture of a pacer lead with vegetation. So in this, this can be present with or without a vegetation on the heart valve. In these patients, usually removal of the device is curative, plus obviously 6 weeks of antibiotics to mop up any remaining bacteremia. But usually it's very hard to salvage these cardiac devices, and that's why we need our electrophysiology colleagues to help us remove these devices. So let's go back to our patient. So our patient didn't really have any CNS, he didn't really complain of a headache, more of neck pain. But when we went and saw him, on his neurological exam, you could see that he was having some word finding difficulties and some slurring of speech. And that's what prompted us to do some CNS imaging. So the CT showed patchy recent infarcts in the paramedian cerebral hemispheres, and they said do an MRI to further classify this. And then the MRI demonstrated innumerable small foci of restricted diffusion throughout both cerebral and cerebellar hemispheres, consistent with multiple ischemic lesions related to embolic phenomena. So, this patient had left-sided endocarditis with embolic phenomena to the CNS. Because of his neck pain, we got an MRI of the cervical spine, and that showed a new epidural fluid collection at the C3, C4 disc level, which measured 0.4 into 1.5 into 3.2 centimeters. and this was suspicious for an abscess. So, this is why this case is very intriguing, because it kind of fits all the possible complications we talk about. So, his management was a pretty multidisciplinary approach. Our neurosurgery colleagues were involved, our orthopedic spine colleagues were involved, and we were obviously involved. And that he had surgical management of his cervical spine. They did a washout and stabilization of his cervical spine, and then for his CNS emboli, he was just monitored very carefully. So other manifestations, sepsis, meningitis, unexplained heart failure. Yeah, we kind of talked about all of these. So, okay, so how do we diagnose, our patients? So obviously clinical history and physical examination. And again, in the clinical history, things to kind of specifically ask about is any risk factors that would put them at risk for bacteremia, whether it's a dental issue recently, dental fillings, a recent abscess somewhere that may have resulted in bacteremia that eventually seeded their heart valves, any zoonotic exposure, high-risk exposures such as IV drug use. So all these kind of details are important to determine if your patient has a high pre-test probability of having endocarditis. And then you do your blood cultures, and the blood cultures ideally should be before starting your antibiotics, but understand that this may not be a case if the patient presents in fluoride septic shock, because you can't, and if obtaining blood cultures is depending on which situation you're in, you need the proper equipment. Sometimes they're done by, phlebotomy or the nurses. So basically, ideally, you need to do blood cultures prior to starting antibiotics. But if the patient is in septic shock, sometimes that may not be the case. Ideally, it should be done at separate venipuncture sites. So if you draw a lot of blood from the same stick and then you inoculate 4 bottles, that's technically one set. So it should be with different venipuncture sites. And then if you're thinking of a zoonotic infection, serology is a cornerstone, because these patients will have negative blood cultures. But again, initially upfront, you are going to rule out bacterial endocarditis, and then based on their history, you can add serological investigations. EKG, echocardiogram, TTE versus TEE, and I'll go over when we go with which one. X-ray chest, basically to look for septic emboli, and then CT chest, MRI spine. Based on, not every patient is going to need a CT chest or MRI spine, but have a very, very low threshold to get spine imaging in somebody who has gram-positive bacteremia and new or worsening back pain, with or without endocarditis. So, gram-positive bacteremia, do a very closed-ended history. Does your back hurt? If it hurts, is the back pain new or worse compared to before? Because you really need to be on top of this and have a low threshold to get imaging. Because in addition to antibiotic therapy, other things we can do to improve outcomes is early neurosurgical evaluation. And then if you have culture negative endocarditis, rheumatoid factor or ESR are parts of the Duke's criteria, which we're going to talk about in our next slide. So these are the modified Duke criteria that you can use in to make a clinical diagnosis of infective endocarditis. And basically, you have major criteria and minor criteria. And major criteria is, you have a vegetation, and then you have a microorganism documented in your patient that is known to cause endocarditis. So basically, I'm not going to go over all of this, but sometimes it's very straightforward. You have a patient who has bacteremia, like our patient MRSA bacteremia. You did an echocardiogram, and the echocardiogram showed a new vegetation. So it's just, a very clear diagnosis. The challenge comes in patients who have who come in for something else. They get an echocardiogram and they have a valvular vegetation, and may or may not have some soft risk factors. And then the question becomes, is this infective endocarditis or is this a non-infective vegetation? And that's where these criteria help us. If you do encounter that situation where there's an incidental finding of valvular vegetation in the absence of bacteremia or signs of sepsis, do not have a reflex to start antibiotics, work them up, do lab work, 3 sets of blood cultures, because it may very well be a non-infective vegetation. So it could be a thrombotic vegetations, myrantic vegetation. So basically history plus lab work is what your go-to should be, and not starting them on broad spectrum antibiotics. But if they are sick, showing signs of sepsis, then by all means go ahead and start broad spectrum empiric therapy. And this is just the Duke criteria again, and you can have these slides to have on hand to help at the bedside to make a diagnosis. Okay, so now TTE versus TE, and this is like $1 million question in ID. When do you get a TTE and when do you get a TEE? So basically it boils down to your clinical suspicion. To make a diagnosis of infective endocarditis, a TTE is not enough if your pretest probability of having endocarditis is high. So going back to our patient, if our patient had a toe abscess and had 1 set of blood cultures positive on admission, and then we repeated them 24 hours later and it was negative, and then his foot abscess and the blood had the same isolate of bacteria, and patient no other risk factors, we got a TTE. The TTE visualized the valves very well, and the cardiologist was fairly confident that I see no regurgitation, I see the valves well, they're functioning excellently, and there's no concern from my standpoint. In that case, I'm okay stopping at a TTE because we have a known source. The bacteremia likely came from the foot, and we have a fairly good study with the TTE that is showing good valvular function without vegetation, and we know that the bacteremia cleared very rapidly. Now, compare that with our patients. Our patient had risk factors for having bacteremia, had no other obvious source of bacteremia, and then he was had very persistent high-grade bacteremia. So come to this part off the table. So initial TTE was negative, but high suspicion persisted just because he was so persistently bacteremic. So we did a TEE, and the TEE was positive. So we kind of went that way. So in his case, if the initial TEE was negative, and because he was so persistently bacteremic, the recommendations are that you should repeat a TEE maybe in a week to see if now he has a vegetation. And the thought process behind that is that if you do a TEE very early on in the course of endocarditis, the patient may have not had enough time to develop a vegetation. So, but if your clinical suspicion is low, you have an alternative source, and the bacteremia clears rapidly with a good TTE, you can stop at that. So basically, that's what it comes down to. And why a TTE is not enough in the setting of high clinical suspicion is case in point to our patient. He had a TTE done, and it was okay. It wasn't the best TTE, had a bit of regurg, but really didn't show us the vegetation until we did the TEE. So that's why it is important to proceed with a TEE when your suspicion is high. So treatment, initially when these patients present, you're going to start them on broad spectrum empiric therapy, and that is usually dictated by what risk factors they have. And then obviously you're going to tailor your therapy to what organism you identify. It's important to make sure that the organism you identify has appropriate susceptibilities, because you really want to pick a drug that is most effective against the organism. You always, as a rule, want to pick a bactericidal agent plus minus a synergy drug. And synergy drugs come in basically with certain organisms and prosthetic endocarditis. And I have some slides to go over that as well. Once you start appropriate antibiotic therapy, repeat blood cultures should be performed to make sure that the bacteremia is responding, and treatment duration usually is 4 to 6 weeks. If in the setting of infective endocarditis, you are having a hard time clearing the bacteremia, always go back to the drawing board. And the questions you need to ask yourself is, what can I do differently? Am I using the right antibiotic to treat this? If so, am I using the right dose? And if you're using the right dose, are you getting appropriate antibiotic levels? And this is where vancomycin comes in. So if you're treating with vancomycin, so in our patient, when we had persistent bacteremia, we made sure that the vancomycin MIC for the organism was good, which it was. We wanted to make sure that our levels were therapeutic, which we were. He was persistently positive just because he had multiple foci of infection that were not addressed at the time. And once he had the debridement of his cervical spine, he did eventually clear. So yeah, and then the other thing you want to make sure they don't have a metastatic focus, which in our patient he did. So right drug, right dose, rule out other places that the patient may have seeded, resulting in persistent bacteremia. Okay, this is just the next few slides just tell you specific drugs with regard to specific organisms, and I'm not going to go over these. You can have my slides, but for streptococci, native valve, this is one area you really need to pay attention to the MIC of penicillin, because all of these will be resulted as sensitive, but what the actual MIC is will help you determine whether you can use penicillin alone, or if you need to use penicillin plus a synergy drug. And if you're using a synergy drug, do you need to do it only for 2 weeks or 6 weeks? So even though all these three scenarios will have a penicillin susceptibility as S or sensitive, you need to pay attention to the MIC because it will change management. Duration, as the MIC goes up, we're usually going to treat them for longer. Prosthetic heart valves obviously is one situation where you will use a synergy drug such as gentamicin. Staphylococcus, again, MSSA versus MRSA, usually 6 weeks of treatment. If we're talking about prosthetic heart valve, we usually add rifampin and gentamicin for the first 2 weeks to help with biofilm penetration and just kind of helping eradicate the endocarditis in the setting of prosthetic material. Enterococci, one change here is, enterococci, traditionally AMP-susceptible enterococci have been treated with ampicillin plus gentamicin as synergy. But recently, over the past, I want to say 5 to 6 years, new studies have shown that if you replace the gentamicin with ceftriaxone, so unusual combination, ampicillin plus ceftriaxone, both beta-lactams, but when used together, patients have the same treatment success as AMP plus gentamicin with, close to no side effects, as opposed to when you use gentamicin, which is a very toxic drug with renal toxicity and ototoxicity. So, and then, so remember that that's a kind of newer change. Again, duration is 4 to 6 weeks. So indications for valve replacement, they're emergent indications and they're urgent indications. And this is where we seek the help of our cardiac surgery colleagues. So severe acute valvular regurgitation or obstruction causing refractory pulmonary edema or cardiogenic shock, and fistula in the cardiac chamber or cardiogenic shock. So, it's a very challenging situation where you ideally want your patient to have sterile blood cultures, because if you're putting in a new prosthetic valve, you really want the field to be clean or sterile before you put a heart valve. But sometimes it's hard to sterilize them without removing the infected heart valve, which is serving as a source of persistent bacteremia. So really a multidisciplinary approach with your surgery colleagues to determine the right timing of surgery. Then they're urgent, and what that means is within the same hospitalization, they should have their valve replaced. So persistent heart failure, signs of poor hemodynamic tolerance, uncontrolled infection, structural issues because of the infective endocarditis, or failure to clear bacteremia despite appropriate antibiotics. And as I said, that's the challenging situation where the surgeons or the surgery colleagues say, hey, I don't want to put a valve in this patient because they're still bacteremic, but our thought process is we've given the best shot with antibiotic therapy and they're still bacteremic, so they need source control. So persistent embolic phenomena despite antibiotic therapy or very large vegetations are also an indication for urgent surgery. Elective, so if a patient has severe regurgitation and heart failure, but they are controlled on meds, they can, we can treat them with their determined course of antibiotics, and then they can come back for elective surgery. And then fungal and gram negatives historically are like a surgical disease, and they at some point do eventually need replacement of their heart valve. Complications, higher mortality in older extremes of age, left-sided endocarditis more aggressive than right-sided endocarditis, what organism they have. So higher virulence organisms such as Staph aureus, our patients are higher risk for mortality as opposed to less virulent organisms such as coagulase negative staph. Local complications, abscesses, fistula, rupture, embolic phenomena, we spoke about those, and then metastatic infections in the spine and joints. So when do you give antibiotic prophylaxis in somebody who has had endocarditis or other patients who are at risk for developing endocarditis? When would you give them antibiotic prophylaxis? So any prosthetic heart valves, including bioprosthetic or homograft, prior endocarditis, unrepaired cyanotic congenital heart disease, completely repaired congenital heart disease with prosthetic material, or repaired congenital heart disease with residual defects, and then valvulopathy in a transplanted heart. So, aortic regurg, aortic insufficiency in the setting of a transplanted heart. So these are the conditions. If the patient is undergoing, for example, a dental procedure, you will prophylax them with antibiotics prior to the procedure to prevent development of infective endocarditis. What high-risk procedures they are? So dental procedures that involve manipulation of either gingival tissue, anything that would, aggressive procedures, especially that would involve bleeding, procedures of the respiratory tract that involve biopsy or excision, GI or GUE procedures in the patients with ongoing infection. So if you have somebody with an obstructed uropathy, they come in with a large renal stone and they have to go in to put a stent in or do lithotripsy, that's a high risk procedure. Procedures on infected skin sutures, or musculoskeletal tissue. So patient has a prosthetic heart valve, comes in with a large abscess on the leg that you need to IND, has lots of surrounding cellulitis. So do go ahead and give them antibiotics. Surgery to place prosthetic heart valves or prosthetic intravascular intracardiac material. What you should prophylax them with, usually our go-to is amoxicillin, especially in the setting of dental procedures. But again, your clinical scenario should dictate what you're prophylaxing them with. Because if somebody has a, as I mentioned, a GU procedure, then amoxicillin is not going to do them much. You should prophylax them with a gram-negative antibiotic, so something like ceftriaxone or cefepime, because if they were to have a bacteremia and then seeding of the heart valve, it's going to be likely a gram-negative organism. And then again, if it's an abscess on their foot and they have a history of MRSA, then they should get prophylaxis with a gram-positive agent that has activity against MRSA. But this is purely for dental procedures, amoxicillin, if they're allergic, clindamycin, or cephalosporin. These are my references, and I will take any questions at this point.
Thank you so much, Dr. Waqar, for a really phenomenal lecture, as always, very thorough overview of infective endocarditis. I would like to hand it over to our audience to see if there are any questions for Dr. Waqar. Does anybody have any questions? I saw.
Hello?
Yes, we can hear you.
Yes, special thanks to Dr. Waqar for what was an excellent talk. Really thorough yet simplified explanation. So I really loved it, and I'm sure the group here shares my opinion about that. So thank you very much.
It was my pleasure.
Now I just have a couple of questions, if you don't mind. Now, occasionally when you go through literature about infective endocarditis, you see this distinction between community-acquired and healthcare-acquired infective endocarditis. Now, is that something that you commonly insist on in your practice, and how does that influence your management of these patients, particularly the empiric therapy?
Thank you for that question. So in our clinical practice, we don't usually use that definition as community acquired or hospital acquired. But as I mentioned during my talk, history is very important. So if you have a person who does not really have a lot of healthcare exposure coming in with, bacteremia after a recent dental procedure or an endocarditis, our approach for them is going to be very different than somebody who has dialysis and a pacemaker. We would usually go broader in somebody who has a lot of healthcare exposure and infective endocarditis. So we delineate that based on their kind of underlying comorbidities and their exposure to the health system, as opposed to a pure definition of health acquired versus community acquired. So if that answers your question, sorry.
Yes, it answers it beautifully. Now, the next point is going to be about HIV infection. Again, HIV infection is sometimes related as an independent risk factor for IE. And usually they mention unusual germs like salmonella or listeria. Now, is that something you've encountered in your practice, and how do you usually approach them?
So interestingly, we haven't encountered that. Even when we do see infective endocarditis in our HIV patient population, it is usually these, the gram positives or the bacterial pathogens I spoke about. So I personally haven't encountered any unusual organisms in the setting of HIV. And Dr. Prakash, I'm not sure if you have, but it's usually kind of the same organisms we see in our non-HIV population. So I haven't personally encountered that.
So actually recently, I discussed a case of a patient with HIV infection, a very low CD4 count, very high viral load, and the patient had infective endocarditis. The organism that was grown was Staph aureus. That was methicillin sensitive. But the physician managing the patient was concerned about the necessity to cover for other organisms, including listeria. Now, in meningitis in patients with HIV, usually empirically we cover for organisms like listeria. Do you think a consideration should be made about that in infective endocarditis in patients with HIV?
If you do have an organism documented or isolated in your patient, which is known to cause endocarditis, such as MSSA, my clinical suspicion for an unusual organism causing endocarditis would be relatively low. That being said, our HIV population is one set of population who, especially if they have AIDS with low CD4 counts, who can have multiple opportunistic, non-opportunistic infections at the same time. So yes, we should look for other things as well, but if you have an organism that is known to cause endocarditis, identified and isolated, I would probably target that and not be that concerned about unusual causes.
Okay, thank you very much. Now, if you have a few minutes, what I'm going to do briefly, is paint you a picture of infective endocarditis in our context and show you all the limitations, and please have you comment on that. Is that okay?
Yes.
So please, so here in Cameroon, particularly in Bingo, we do see or at least suspect infective endocarditis regularly. And the main risk factors that we do have include rheumatic heart disease and poor dental hygiene, but not so much IV drug use. I'm sure you could have guessed that. So very few people or patients do use IV drugs. Now, in terms of investigations, first of all, we don't have TEE available. Now, would you consider that as a big limitation in our practice? That's the first question concerning that. The second is, you did recommend repeating TEE in case of negative TEE following a negative TTE, repeating it in the course of the illness. Now, would you also recommend doing serial TTEs in these patients when you don't have TEE available?
Yes. If there are abilities to do a TEE should be done in patients that we have high clinical suspicion of endocarditis, but because, as I mentioned in my case, a TTE is limited in what it can tell us about infective endocarditis. So yes, a TEE should be done if the resources are available. If resources are not available, then a TTE could be repeated. So if an initial TTE on presentation was negative, you could try repeating it, in 10 to 14 days. And not only trying to look at vegetations, but also kind of looking at valvular function. So if somebody had mild aortic regurg initially, and 2 weeks later, even though you still don't see a vegetation, but the aortic regurg has worsened, that in itself should prompt you to make a diagnosis of endocarditis and treating it as such. So yes, a TTE can be repeated in the setting of limited availability of TEE, understanding that a TTE is still limited in what it can tell us. So if despite a negative TTE, even in 2 weeks, if your clinical suspicion is still high for endocarditis, then treat it as such.
Thank you, brilliant. So the next question is going to be about cultures. Now, the recommendation 3 sets of blood culture. I don't think it's ever been done in this facility. And one of the main limitations about that is the cost. It just cannot be afforded by the average patient we have in India. Now, what comment can you make about just having a single set of culture in these patients, which is unfortunately what is the common practice around here?
So again, we're in a clinical setting where we are unable to do 3 sets of blood cultures, it comes down to any blood culture is better than none. But it is the luck of your draw because, depending on where the infection is, if it is a big intravascular focus and they have very persistent bacteremia, you are likely to pick that up with one set as well. But sometimes, as you know, bacteremia can be intermittent and very dependent on the volume of blood that's drawn too. So if it's a single blood culture with not much volume drawn or inoculated in the blood culture bottle, even though your patient may truly be bacteremic, you may not be able to capture it. But again, coming down to a setting where you don't have the ability to do multiple sets, I think one is better than none. So.
The last point again, concerning the limitation is going to be about treatment. Now, IV antibiotics for 4 to 6 weeks is another big point. Most patients just can't afford that. And the confession is going to be commonly what we do is get an oral relay after a couple of weeks or 3. Oral relay to oral antibiotics, actually. So what would be your comment about that?
Yes, so I know of other countries, other developing countries. I trained in Pakistan, and I know in Pakistan the practice has been traditionally to do a couple of weeks of or IV antibiotics and then transition to PO. And historically or by word of mouth, these patients do well, but there is not much published data. But I know I have seen some recent published data which says that if they cleared very quickly, they don't have other risk factors, and they don't have major valve destruction, sometimes a step down therapy is possible. But honestly, I haven't seen any concrete published data to support that. So in the United States, we continue to recommend 6 weeks of IV therapy as standard of care. But I do know of other places outside of the US that have practiced that model, and their patients do well.
Okay, great. That's all I had. And there's nothing else from our group. So thank you so much. This was a really excellent talk. Thank you.
Thank you.
Thank you again, Dr. Waqar, and to everybody who attended. Many thanks to you, Praniti, and to Dr. Rahani and the entire Health for the World team for this tremendous opportunity.